Hello, and welcome to the Prevent Cancer Dialogue. Today, we're discussing the role that patient navigation plays in improving cancer screening and early detection. I'm Heather Mackey, Senior Director of Cancer Prevention and Early Detection at the Prevent Cancer Foundation. Today is the second in our series of 3 webinars aimed at discussing strategies for cancer prevention and early detection across all communities. In 2024, an estimated 2 million new cases of cancer are expected to be diagnosed in the United States. Early detection allows for cancers to be found at earlier stages when more treatment options are possible and outcomes are improved. However, barriers to cancer screening and follow-up exist and can interfere with people seeking or completed needed services. Patient navigation has been demonstrated to be an effective strategy to overcome these barriers and improve screening. Today, you'll learn more about how this work is accomplished, including lessons learned from the field. Whether this is your first time attending the Prevent Cancer Dialogue or if you've joined us before, I think you'll find the most rewarding aspect of the dialogue to be the exchange of ideas among speakers, moderators, and most importantly, you. We hope that you'll use today's conversations as a place to brainstorm, collaborate with other attendees, and bring ideas back to your community to enhance or expand your cancer prevention and early detection practices. Make plans to join us for our final dialogue webinar, which will take place on September 11th and provide an update on the latest in prostate cancer screening. You can learn more about this session and register for the event by visiting preventcancerdialogue.org. Today's event would not be possible without our sponsors. I would especially like to thank our gold sponsor, Exact Sciences, and our silver sponsor, Asai, for their generous support. Thank you for believing in a world where cancer is preventable, detectable, and beatable for all. I encourage you to extend today's dialogue to your networks on social media by using the hashtag PreventCancerDialogue. We always love it when you tag us at Prevent Cancer as well. With that, it is my pleasure to introduce our speakers for today's webinar, beginning with Monica Dean, Director of Patient Navigation and Program Development for the Academy of Oncology Nurse and Patient Navigators Plus. Monica will set the stage for our discussion, drawing from her vast experience in patient navigation over the past 2 decades. Later, we have an exciting panel presentation featuring Prevent Cancer Foundation funded community grantees and researchers who will share their best practices using patient navigation within their communities to reduce barriers in cancer screening and early detection. They include Dr. Paris Thomas, Executive Director of Equal Hope in Chicago, Illinois, Hyun Hwa, Director of Programs with Vital Access Care Foundation in Orange County, California, Dr. Michelle Williams, Associate Professor in the Department of Global and Community Health with George Mason University, and Courtney Downs, Viral Hepatitis Treatment Coordinator and Health Educator with the Virginia Harm Reduction Coalition. In each of their presentations, they will talk more about their organizations and their work. And now, please welcome our first speaker, Monica Dean.
Well, good morning or good afternoon, depending on what part of the country you're in, joining us today for this Prevent Cancer Foundation Dialogue. I am really excited and honored to have been invited to speak with you all today on patient navigation and its role in improving cancer screening and early detection. I am Monica Dean, Director of Patient Navigation Program Development with the Academy of Oncology Nurse and Patient Navigators. And so to kick off this session, I am going to be speaking with you about patient navigation and its role in improving screening and early detection. So let's kick this off. Quick objectives, high level. I did want to provide an overview of the Academy of Oncology Nurse and Patient Navigators, who we are, and then at the end of the presentation, I will be sharing resources to support your navigation programs of practice. I did want to highlight the foundation and evolution of oncology navigation. We have a rich history, which many of you probably are aware, and if not, I'll be sharing some great highlights. And then wanted to, again, highlight the landscape from where we started to where we are today. And then demonstrating also and sharing the community guide and the evidence-based practices that actually in 2023, I'll go into more detail, reinforce the importance of patient navigation as it relates to cancer screening. So who is AONN? We are the largest specialty organization dedicated to improving patient care, quality of life, by defining, enhancing, and promoting the role of oncology navigators. Regardless of your scope of practice, we want to be the home of patient navigators, oncology nurse navigators, social work navigators, and as the field continues to evolve, we want to be that home for you, regardless even if your title is not a navigator. You may be doing the roles and responsibilities of a navigator. We were founded back in 2009, providing that network for all professional navigators involved in navigation. We are the professional association consisting of 9,000 members. And then also we have the Oncology Nurse Navigator and Patient Navigator certification via our Foundation for Learning. So I always like to give a hat off to our two foundational leaders, Dr. Harold Freeman, which many of you probably are familiar with, as we like to endearingly call him the godfather of patient navigation. And then of course, AONN's founder, Ms. Lily Shockney. Really quick, I wanted to highlight some early published results as it relates to navigation. Obviously, for the purpose of today's call and today's meeting, we saw increases in participation in cancer screening, which is why we're here today. Adhering to diagnostic follow-up care from following abnormal findings. Each one of you providing health education across the cancer continuum, providing psychosocial support, whether that is from a social worker or you as a navigator and in the community, just listening to your patients and families and caregivers. One piece that we found early on was that navigation was ill-defined, but I'll be really excited to share with you some exciting developments since all of these early findings. So let's look at the landscape from where we started to where we are over the past 30 years. The report on cancer, which many of you know, Cancer in the Poor, which was done by Dr. Freeman, and I'm not going to go through all of these for the sake of our time together. But the Patient Navigation Research Program was one of the first large research studies to show the impact of navigation in our communities. As we continue on, we see that AONN was founded in 2009. We started seeing, for example, the Commission on Cancer and standards around navigation. And then moving forward, we started to see really some honing in on defining the role and scope of navigators. So you see here that ONS developed core competencies for navigators. Many of you, and I hope, have participated in the George Washington Cancer Institute. They came out with core competencies for patient navigators. Again, we launched our certification exam in 2016. And then lastly, two other pieces, and we'll talk about this in more detail later. In 2022, the Professional Oncology Task Force released the Oncology Navigation Standards for Professional Practice. The first time in our 30 years of navigation, we sat down and defined the roles and responsibilities currently of patient navigators, nurse navigators, and social work navigators. But we know as the field continues to evolve, we will be reassessing what those standards look like. And then in 2023, CMS announced changes for paying for principal and illness navigation. This is the first time that finally navigation is being recognized as a reimbursable service. There's still a lot of work to be done. And for example, currently screening is not being included. However, what I would suggest, and please reach out to me directly, I'm sure there's going to be another comment period, and you all need to be that strong voice of how important screening and early detection is to be included in these reimbursable services. All right, so let's talk about some barriers to screening. But before I do that, I really want to reinforce the definition of patient navigation, which all of you probably could speak to in your sleep. But patient navigation is individualized assistance offered to patients, to families and caregivers to help overcome health system barriers and facilitate timely access to quality health, psychosocial care from pre-diagnosis. So what we're all here for is that screening aspect through all phases of the cancer experience. So I just wanted to hone that message back home. So as we talk about barriers to cancer screening, we know the top, even in through treatment navigation, transportation is that top barrier for patients, whether they don't have a loved one that they can help take them to and from their, let's say, even screening or their treatment. We know transportation is a huge barrier for patients. Lack of insurance. It is found that people who don't have insurance tend not to be screened as often. For example, colorectal screening among uninsured people aged 50 and over was 30% in 2018. That is a staggering number, if you ask me, which, and compared to that, to the approximately 2/3 of people with private insurance who got colorectal screening when it was due. And then we know the issues with language barriers, that communication within the healthcare system, that is a no-brainer. You know, we'd like to think that all systems have translation services, which we know that they do, but that is a barrier for patients getting into cancer screening. And then, of course, cultural beliefs. Some people may have migrated from the US, where culturally you only go to the doctor if you're sick. People may think, well, if I'm getting a screening, but I feel fine, they may put off cancer screening, and then thus potentially leading to a later stage cancer diagnosis. And then sadly, prior negative medical experiences, whether it is from that person individually, a loved one, a caregiver, etc., may pull them back from going into their regular cancer screenings. All right, I wanted to highlight the various roles in oncology navigation. These again came out of the definitions from the Oncology Navigation Standards for Professional Practice, and endorsed by professional organizations, as well as a community comment period before we published. But as you know, a community health worker is that frontline public health worker who is a trusted member of the community and many times looks like that community to help, again, be that voice for the patient, facilitating access to services. The oncology patient navigator is a professional who provides, again, that individualized access to assistance to patients and families affected by cancer to improve access to services. And again, going back, you're going to hear this theme of addressing barriers to care. What can that patient navigator do to facilitate transportation, to getting them into screening, getting them into the doors of the healthcare system? The oncology nurse navigator, the professional RN with oncology-specific clinical knowledge, who offers, again, an individualized assistance to patients, families, and caregivers. And then lastly, but not any less important, is our professional social work oncology navigator. Typically, we see master's degree in social work and providing that psychosocial care to patients. And many you'll see within these interwoven, some of these responsibilities may cross over, but the most important piece to this puzzle is that each one of these individuals are practicing to the top of their scope of practice and not working outside the boundaries of their role as well. All right, I want to speak just really quick to the community guide. These recommendations are the gold standard to work to protect and improve population health. And these, the community guide is a collective evidence-based recommendations from the Community Preventive Services Task Force. And I want to really reinforce the fact that evidence-based recommendations. We know that navigation has been researched for a number of years. So really exciting to share this next slide. But they are really making these recommendations about effectiveness and economic impact of public health programs. And you can see right here the link to access the community guide and its resources. So I hope you take this away as a resource for you in your practice as well. So very exciting, in 2023, the Community Preventive Task Force recognized patient navigation services as it relates to increasing breast, cervical, and colorectal cancer screening. To me, this is just a nod to the importance of early detection of cancer. And they also, patient navigation services, as we know, are expected to advance health equity. And I know later on in our discussions today, we will hear from our esteemed panelists and how they are addressing health equity in their communities. And then kind of going, dating back a little bit, the community guide also recognized community health workers. Again, that frontline representative of their community to help really drive education, community education, and then getting individuals into appropriate screening and healthcare. All right, so I am not going to spend too much time on our resources, but I did want to share some AONN resources that, again, you can take back to your practice. In 2020, AONN, in collaboration with the American Cancer Society, released the Metrics Toolkit as a result of a study conducted by the Academy of Oncology Nurse and Patient Navigators. We know that navigators and programs need to demonstrate the return on investment of their program, and this toolkit goes through 10 metrics as well as case studies from that study that I just discussed. So please take advantage of this, and of course the resources I know are going to be uploaded to the platform today, so please take a look. And this is where my passion really lies, and I get really excited, is, as I mentioned earlier in the presentation, the oncology navigation standards of professional practice. These identify the best practices in order to promote high level of navigation. They are intended to be a guide for professional practice, regardless of your setting and regardless of the role and scope of a navigator. And then you can see here the organizations that help put these standards together for the first time. This is where I get so excited. For the very first time in our 3 decades of navigation practice, AONN, Association of Social Workers, AFONN, which is the Pediatric Navigation Association, ONS, and then of course we had a community voice from Cancer Support Community and Smith Center for Healing of the Arts. And also we gave a great thanks to the National Navigation Roundtable, who helped to disseminate and also provide guidance for this. And again, AONN has a plethora of resources. Just to highlight a couple really quick. BOLD, which is our mentorship academy, where we basically pair up a mentee and a mentor, so that way they can help support one another as they grow in their work in navigation. Catch, this is where I hope each one of you will take an opportunity. It's catching and addressing threats to care and health. This is the opportunity for navigators to share your stories. We find that navigators may not want to boast on the incredible work that is being done, but it really is the opportunity to say, hey, I caught this patient not coming into treatment because of, let's say, their barriers to care. But because of my facilitation and my navigation, I was able to bring them into the healthcare system in a timely manner and to ensure that there is not a late stage diagnosis. So please, if you have these stories to tell, we would love to hear from them. They are published in our journal, and it's an easy way to get published with really a low level of effort too. We have a podcast. We have, I don't know how many series we have now, but we have a great podcast because we know that not all navigators can join webinars, during the day, but this might be a great opportunity as you're driving home from work. And then we also partner with Pfizer on a number of toolkits. This one is our latest one that we've updated, and it provides and explores the evolution of navigation, best practices, and strategies to encourage effective decision-making throughout the cancer continuum. And then what I hope each one of you also take away, we do have 11 national committees, and one being Screening, Early Detection, and Treatment Committee. And this will be a great opportunity for you, if you are an AONN member, to be that voice and have a national platform to be that voice in your role as a navigator. And then last but truly not least, we have individuals from all over the country here today. And we have 30 plus local navigation networks. Some may be sitting in your backyard, and we also have virtual networks, as you can see on the screen. So To go to the full roster, you can go to the AONN website, and we really encourage individuals from all roles and responsibilities to join a national local navigation network. You do not need to be an AONN member. However, we of course would love for you to join AONN, but a great opportunity to network within your local community. And that concludes my presentation. So thank you. I know we will be addressing questions after this presentation. So thank you so much. Drive some questions into the chat if you haven't already, and we'll get to as many as possible. Thank you.
Thank you, Monica. We are so excited to have you here today, and thank you for that excellent presentation. As Monica mentioned, it's time now for the questions from the audience. We've had some great questions already submitted, but it's not too late. If you haven't already done so, just please enter your questions using the Q&A icon at the bottom of your Zoom screen, and we will get to as many of them as we can during this part of the presentation. So Monica, the first question, for those who may not be familiar with the George Washington core competencies, can you talk a little bit more about what they are and how they can be utilized?
Absolutely. They really go to the core of the navigation. I don't want to say basics, but to the core of what navigation does. So, and of course, I probably should have it up on my screen, but it's looking at obviously insurance education. It's looking at what is navigation. It's looking at talking about cultural competencies across the board. So I can definitely put that in the chat as well to share. It's actually being updated as we speak. I've had the honor to be a part of this. I was at the beginning of it, and now they're updating. So it's definitely something that we can use. And it's a free course for folks to sit down and take. It's, I believe, 20 hours, but it's obviously self-paced for the individual that's doing it. So it's not as though you have to do it, let's say, within 1 month, because we know how busy everybody is. So I'll definitely put that in the chat for everybody to see.
Yep, so we'll make sure and drop that in there so that people can see it, as well as you mentioned in terms of afterwards, some of the information there. So we'll make sure to get that in.
And it's so applicable. I'm sorry, I just completely interrupted you, but it is really applicable, I think, to the foundation of navigation. So for somebody that's walking in for the first time, they're like, wow, this seems like a great career path that I'm really interested in because I love helping patients. I think it really walks through what navigation is. So, I mean, I highly recommend it.
Yeah, and that is perfect, because actually my follow-up question was going to be, does it matter if someone, can someone benefit from that if they're completely brand new, or if they're experienced, or similarly,
Both.
with the different type of navigators that are out there, is it geared more towards one rather than another?
I would say it is, I mean, I've seen across the board, because we get this question a lot. It was built off for the patient navigator. So going back to the presentation and thinking about the patient navigator, nurse navigator, and social worker. But I think all navigators, regardless of role and scope, can benefit from the education from that course.
Great,
and
great.
Regardless of if you're a novice or experienced, depending on, where you are in your career.
Thank you, thank you. Someone is asking, is there any opportunity for a non-member to participate in the Screening, Early Detection and Treatment Committee? I know you mentioned that it was geared towards members, but are there opportunities for non-members to participate? And for those who are members of AONN, how do they join the committee, or how do they get involved?
So we do say that folks who join that committee or any of our committees, we would like folks to be a member of AONN. So I know you've got my information, and we can put that into the chat as well if you want to reach out to me, and we can talk offline. But we do require that folks are members of AONN to be a part of the committee. But we also are building this committee, and I was looking at the 400 plus folks we have on the call, and I see some great familiar faces. And we do want to really build this committee. So because it was new, and I thought I saw Kim Parnham on here, and she was one of the ones that reached out to us during COVID and said, this is going to be the time that we need this committee. So we're building, we have some great opportunities. So the more, the merrier. So please definitely put my information in the chat.
Will do. Thank you. Next question. How often is an oncology navigator interacting with the community health workers at the community-based organizations? We found that it's best to collaborate to bring the resources to the people and make them understood in a culturally sensitive manner.
That is a great question. I think even looking back to my American Cancer Society days, we were trying to figure out how can we tie all the pieces together, from that community health worker, getting them into the, connecting the dots with, let's say, an ACS navigator or a nurse navigator or that health system navigator. I hate to say it, I don't have the answer, but I think that is a huge opportunity for collaboration, thinking about the Community Health Worker Association and really building these bridges. And I'll put a flag for the National Navigation Roundtable. This may be an opportunity for them to say, hey, we have all these organizations, ONS, us, CHWs. How can we really put that care transition together in a much more professional, not professional, but tied together practice?
Cohesive way. Yeah, absolutely. Absolutely. Another audience member is interested in learning more about or addressing the barrier of transportation to follow up diagnostic colonoscopy following a positive non-invasive test. Specifically, do you have any thoughts on partnering with rideshare services or getting that reimbursed?
So I know just in my past days, and again, I'll pull back my American Cancer Society's days, organizations have, and even healthcare systems have partnered with rideshare in order to figure out, to get people into care. I don't know where some of that still stands, but that could be something that AONN could definitely, I'll say, survey and find out what systems are doing. And I don't know where the American Cancer Society stands anymore, but there was definitely a big push during just getting people into treatment. But it's great because we can't solve the transportation solution alone. We have to be in partnership with many individuals.
And definitely, certainly looking at the geographical differences, even within a city, just the different things that are there, what may work, but really that cohesion leaning against what can we learn from one another is so important.
Well, especially, I think about Linda B. out in Colorado, where she's got, individuals that are traveling hundreds of miles. And then you do, to your point, around the inner city. I mean, it's not apples to apples, but it's definitely almost like another coalition that we need to put together so we can figure, help that.
Yeah, most definitely. Can you speak a little bit to the differences between a patient navigator and a community health worker, as well as the similarities?
Yeah, absolutely. So traditionally, and I know there's many people on this call that can probably also speak better than me, the community health worker really was that, again, is the way I look at it. They are the face of that community, bringing them in, education, etc. And then the patient navigator, they do a lot of similarities, in my opinion. They really do a lot of similarities. Removing barriers, speaking, let's say, Heather, you're speaking to me. I don't want to go in to get a, mammogram. Well, here's what you're gonna, here's why I think you need to do it. And then handing over that patient to the patient navigator, and they're collaborating together and they're communicating together on, okay, Monica doesn't have transportation. She didn't have childcare. I really do see there's a lot of similarity in roles. It's just where they sit versus in the community versus in the healthcare system. So I don't know if that really helps answer the question.
It does. I think it's evolving. I think, certainly.
It is. It's always going to be evolving.
Yeah. Yeah. Any resources that you would recommend for those that are interested in becoming licensed or certified as a navigator? And this particular question is coming in from someone that's a patient navigator for Horizons Cancer Coalition.
Yeah, absolutely. So we will be updating. We did pause AONN certification just for a number of reasons. We went through a job task analysis, and then of course the CMS reimbursement threw us for another loop, and making sure that we were fully aligned with which we are. So we will be reposting on our website resources to help prepare folks. And then in addition, if you go to AONN and then go under navigation A to Z, we do have for reimbursement a couple articles that have a ton of training resources. Mandy Pratt Chapman, who is a great partner, posted 2 great articles. If folks want to look into those, whether you pay for them or free resources. I know Komen just came out with a new one as well, depending on, and that one's actually not necessarily, there's two, breast focus, but there's also a navigation one. So there's really a lot. And then again, I can help add some of these resources for you guys.
Thank you. Can you speak a little bit more to the navigation metrics in the toolkit? I think that it can be very challenging to get administrators to buy into the concept of navigation, despite the vast evidence that's out there showing its effectiveness. What advice can you provide to those that may be on the call today that are interested in implementing patient navigation into their cancer screening work, but meeting with resistance?
So I think twofold is one, find a champion. You have to find a champion within your healthcare system. And that might be hard to find at first, whether it's a physician, whether it's the administrator, but then demonstrate and have that elevator speech of why navigation is important, because to avoid the outmigration at the end of the day. Hospital systems don't want to lose these patients. And that's what we keep seeing from the research and from the qualitative and quantitative stories, is that navigation kept me in the system because I had I'll just say Monica Dean. They had somebody in that system to keep them there. And that's the bottom line. It's the ROI. The one thing with the metrics toolkit is, one, we came out in 2018, whatever year it was, with the 35 metrics. No system is going to be doing 35 metrics, nor even within the metrics toolkit, the 10. Those were the 10 were a part of the study, but you have to figure out what makes sense and what kind of puts that light bulb, I'll say, for administration. So we were very purposely in the case studies to say, hey, I'm an academic center, I am this community center. So that's what I would take back to heart, is seeing what makes the most sense for that center, and then seeing what kind of resonates.
Thank you. And looking at the clock, this may be our last question, and unfortunately, it's probably the more complicated one. So in 90 seconds or less, can you talk a little bit more about the lack of coverage for cancer, for screening in particular, when we look at CMS reimbursement and work that's currently being done to advance that?
So unfortunately, I wish I would have been a part of, the government side of the house. I think it was the first time, because navigation, one, was ill-defined. We did the standards, and the standards do currently sit in the treatment phase. But that's phase one of this. So twofold, really quick, because I know we're going to run up on time, is when the open comment period opens again, and I'll make sure that everybody knows about this, reinforce the importance why we have to include screening. Screening will stop the late stage and all the later stages. The standards were developed again around the treatment, but we can rechange those, and we have a link to give us that feedback. And so we are looking at revising them every 5 years. We're about to hit the 5-year mark pretty soon. So that piece of it, and we all have to be the active voice. We have to be the active voice. So that's my biggest encouragement.
Yeah, most definitely. And with that, thank you again, Monica, for sharing your expertise with us. Monica will be back to moderate the best practices panel that'll be coming up in just a little bit, where you'll hear more from our Prevent Cancer Foundation community and research grantees about their work in patient navigation, cancer screening, and early detection. We've had a lot of comments for people for opening up the chat, so we're doing that. If you'd like to drop in some things that perhaps you and your institution are doing that you'd like to share with the audience, please do. Regarding questions that are in the chat that have not been answered, questions in the Q&A that have not yet been answered, go ahead and leave those in. What we will do is we will work to get those questions answered during our moderated session following our best practices panel. And for those questions that we're not able to get to during our live event today, we will be sure to get those questions answered for you and out following the event. But before our panel, let's first hear a word from our gold sponsor, Exact Sciences.
Hi, I'm Billy Daniels. Exact Sciences continually focuses on navigation programs to support our patient screening journey. We know that getting patients screened is an important step in preventing cancer, and that these programs screen more patients. Our patient navigation program is a supportive tool that helps people get screened because we know that every screening journey is unique. It begins as soon as tests are ordered, taking some burden off the clinics. Key touchpoints include reminders, test results, status updates, recommendations on next steps, and clear guidance to talk with their provider upon a positive test result. Our patient navigation program starts with higher frequency at the beginning of screening, with persistent messaging to get patients to prioritize their screening. This frequency is tapered over time, but continues for a year because we know long-term reminders can still get more patients screened. Every screening journey has challenges, which is why we build encouragement into our navigation programs. Life can get busy for both patients and providers, which is why we focus on creating patient navigation that fits into their lives. In fact, we bring the test right to them and can pick it up when complete. More patients are starting to prefer digital approaches and self-service tools, but we know some still prefer the human touch. Having a digital companion and traditional mailers and phone calls are some ways Exact Sciences make sure each patient is covered. To promote health equity, we make information available in multiple languages and make our instructions easy to understand. We help patients navigate insurance, and through our continued communication, patients get the right support for their personal needs. Cancer screening is a lifelong journey, and navigation programs help patients understand the steps, complete the screening, and follow up when appropriate.
Hello, my name is Paris Thomas, and I'm the Executive Director of Equal Hope, and this is about our patient navigation model here in Chicago, Illinois. Equal Hope was founded in 2008 based on data showing that Black women were 62% more likely to die of breast cancer than white women here in the city of Chicago. This was interesting data as the years prior, there was almost no disparity between Black and white women, and here in the city, many people, many physicians had contributed to biological differences. But we know now that there were no biological differences between white and Black women's breasts. What it was ultimately contributed to was structural racism and how people accessed care here in the city of Chicago. There were three main emphases on this. First, the quality of mammography, the quality of treatment, and access to mammography. Where you live in Chicago matters. And so Equal Hope was founded, which was formerly called the Metropolitan Chicago Breast Cancer Task Force. And our mission is to save lives by eliminating health inequities. Equal Hope has a unique approach to the work that we do. We use a three-pronged model to be able to accomplish a lot of our initiatives. The first is a quality measurement and improvement program. We advocate and produce policy for change. And then we have an outreach, education, and patient navigation program. Our patient navigation program is really special to Equal Hope, as many of our patient navigators have created relationships with a lot of our clients and been able to get those who are most vulnerable into care and access to treatment. So Equal Hope doing outreach and patient navigation in the community. We break our program out in two. We have community health workers who are out in the community connecting with individuals who are disconnected from the healthcare system. They're overall reaching over 100,000 women in a year. They're providing education to 80,000 in community spaces, providing that preventative education as well as educating them on the Equal Hope program. From there, they then connect them to our patient navigators who are navigating 2,500 plus women to high quality care. And our loss to follow-up rate is an impressive at 4.5%, which is even lower than a lot of our hospitals here. So Equal Hope's program pathway is very simple. The way that people get in contact with Equal Hope is through three methods: through either referrals from our physicians, our community partners, or some of our medical homes, through direct community outreach, meaning they ran into one of our community health workers, or client initiated, meaning they had a mother, sister, friend who went through our program and they got connected that way. From there, the client then completes an intake form and they're matched with a patient navigator. They're matched based on usually community area, linguistic needs, and service area type. And from there, that navigator then enrolls them and works with them throughout certain programs. Equal Hope has the Illinois Breast and Cervical Cancer Program, as well as our general cancer screening program, and then we're a part of some other programs. The patient navigators in this box at the bottom specifically are providing multiple services, including appointment scheduling and reminders, transportation support, healthcare insurance navigation, cancer treatment assistance, and ensuring adequate follow-up. So our patient navigation model is really special to Equal Hope. It works because Equal Hope ensures that all of our patient navigators and our community health workers actually come from the communities we serve. All of the pictures you see here are actual patient navigators who work for Equal Hope. And so we ensure that they have a lived experience that matches that of the community so that it can align. Ensure that there's a connection created that is not just about healthcare, but about the person. So some of the areas that works for Equal Hope is, for one, trust. So we build trust with the community, ensuring that we can ensure people to get to the care they need. We ensure there's an authentic lens used, ensuring that we can connect with people and they can connect with us. We follow up and engage. Just because you don't answer the phone once doesn't mean we give up. Our patient team actually does an amazing job of ensuring they can call people through multiple times throughout the day. For example, a lot of the clients we're serving have typical jobs that fall within the 9 to 5 realm. They have children. So calling me throughout the day probably is not the best method. Sometimes we have to stay later in the day and call, but ensure that follow-up anyway. We also send out constant mailing, emails, sometimes do home pop-ups. As a community-based organization, we get to be a little bit different in that way, particularly for women that need to go through treatment. We do have a lot of women sometimes who are just like, it's too much, I don't want to go through treatment. Our nurse navigator is able to come to their homes and talk them into why going to treatment is important and why they should prioritize their own health. We also provide social needs assessments, and then we assist through relationship building, and we ensure cultural and community alignment, as I spoke about earlier. So cancer navigation and post-treatment navigation. Equal Hope is always servicing the person, not the symptoms. For example, we have a nurse navigation program where we have a nurse navigator embedded into 3 Southside hospitals here in Chicago. Those Southside hospitals are safety net facilities that have limited resources, and we're providing a free resource by providing a nurse navigator who helps women onward from diagnostic into treatment. And this is amazing because she's usually able to help them along that process, but also get them into comprehensive care. So treatment services not only address the individuals, but their families. We ensure that families are educated, that the patient can advocate for themselves, that their family is knowledgeable about what is happening. A lot of times, a lot of women in our areas, and specifically here in the city, do treatment alone. Sometimes they don't want to burden their families and they just kind of like, I'll just deal with it. But we believe it's important to bring them in and educate them so they can properly support the client through treatment. And so a quote that I use in our presentations is from one of our patient navigators, Orletta Garman, is people don't care how much you know until they know how much you care. And so this is the Equal Hope patient navigation model. You can feel free to follow our work or invest in any type of way. Our website is www.equalhope.org. We are based in Chicago, and join us. There's a lot to do and a lot of lives to save.
Hello, everyone. First, thank you, Prevent Cancer Foundation, for the opportunity to share our work in the community. My name is Yung Hua, the Director of Program at the Vital Access Care Foundation. We previously known as the Vietnamese American Cancer Foundation, also VACF. We founded in 1998 to address cancer at the top cause of mortality in the Vietnamese community by a group of local physicians and cancer survivors who see the need for material and services in language and culturally appropriate. We serve it Orange County and Greater Los Angeles area with the CORE program, and CORE stands for first, the Continuum of Cancer Care, addressing cancer, what we talk about today, that focus on outreach education, detection, navigation, and support, and always for outreach education and navigation, where we focus on other disease prevention and general social services. We also amplify the community voices in research engagement. And the last but not least, the Equity Coalition and Community Building is a newer program in which we are the founding member of Orange County Cancer Coalition, or OC3, in 2009, and the Orange County Asian and Pacific Islander Task Force, or OCABI Task Force, in 2019. As I mentioned, VACF focuses on the Vietnamese community in Orange County, California. This is the largest Vietnamese community outside of Vietnam, stemmed from a refugee population. According to census data and the American Community Survey, this community has high rate of foreign-born individual with limited English proficiency, especially among senior, as you could see the number on the screen. 39% of the household within the community experience linguistic isolation. This community also have lower level of education compared to total Orange County population, with second lowest educational attainment and lower rates of completing high school and bachelor degrees compared to the total Orange County population, as you could see with some of the statistic information here. These factors contribute to high rates of cancer mortality in the community. Is due to cultural and language barrier. And I would like to talk a little bit about the stigma, is that within our community, there's a lot of misinformation and stigma around cancer, that cancer is associated with the death sentence. There's also some of the belief that cancer is a terminal illness, and you get those illness is due to some of the karma, you have done something bad in the past. So it's create a barrier for individual to seek for help and support. It's also that symptom-based care-seeking behaviors among the community. There's a saying that don't go to the doctor, because if you go to the doctor, you find out that you're sick. So why would you go unless you feel something, right? With the low health literacy, make the screening become being overlooked within the population. And last but not least, it's very important to mention the access to care portion. Many of the immigrant and refugee individuals find it challenging to navigate the complex healthcare system in the US. So the Continuum of Cancer Care program aim to address the challenges to two different stages of care, which is pre-diagnosis, where we focus on the outreach education detection through three main programs. Women Health Program address breast and cervical cancer, the viral hepatitis and liver cancer, addressing high rate of hepatitis in the community. And the third one is the colorectal cancer programs. These are the programs that's long run for over a decade at VACF. We also do some of the work addressing other cancer like skin, lung, and prostate cancer as an opportunity come up or partnership come up. For post-diagnosis, we provide the peer-to-peer support and the consultation and tailored service navigation for those who are diagnosed with cancer. As you could see, our program adhere to the framework of outreach and education, patient navigation, screening, and then the care coordination if they are diagnosed with cancer. All the activities mentioned are provided by bilingual and bicultural staff and volunteers to ensure that cultural and language responsiveness. And we also utilize the trusted messenger in the community to be the health champions that will raise the awareness, provide the education, and to address the stigma of cancer in the community. We also offer the services during flexible hour, location, and format through the partnership with churches, temple to provide education and screening event during the time that many community members come to worship, or with vocational school to provide that sort of services during the break at the vocational school. Those are the entry point of many immigrants. And one of the example that I want to share is the shop and stream, which is we run the food pantry and we do it in the format of like a farmer market that community member could come and pick the food item that they need and provide the screening on site. So that encourage people to come and get the screening as well. And group and one-on-one tailor individualized navigation to address the social determinant of health also really help with transportation, in-kind incentive for screening, and all the practices mentioned above are based on the partnership with many local provider, community-based and faith-based organization. I just want to share with you that through 25 years of addressing cancer in the community, our impact has grown significantly from serving a dozen of people from the beginning to now serve like 10,000 community members a year with like 60 education activity and screening on a monthly basis with different kind of screening like CBE, mammogram, hepatitis fit kit. with 1,000 of individualized navigation session every year. And I just want to leave you with some of the key takeaway that when working with specific community, especially the underserved minority group, it's critical to have trusted messenger in the community, mobilize the resources to serve the people where they are, and then tailor the services to their need, and collaborate with a local partner. There's also some potential in the work that we do that we currently try to develop the community health worker with the local managed care plan under the CalAIM initiative through this California Advancing and Innovating Medical Program that we hope to expand the work to train more community health worker in different community like LGBTQ, Latinx, Black, Native American. And for us, we would like to leverage our partnership with other AA and XBI serving organizations in the OC API task force to get the same framework implemented in the other AA and XBI communities. And thank you so much for listening to my sharing.
Hi, I'm Dr. Michelle Williams. I'm an associate professor in the Department of Global and Community Health at George Mason University. And today I'm going to be talking with you about a program that we recently completed that was focused on training community health workers in Mississippi to deliver information about lung cancer survivorship. It's the Mississippi Lung Cancer Survivorship ECHO program. And you can see here that members of our team that came together to bring this amazing program. They came from all different types of organizations, including the American Cancer Society, University of Mississippi Medical Center, and St. Dominic Baptist Hospital. Our project was funded from the Mississippi State Department of Health Comprehensive Cancer Control Program. We decided to focus our program on lung cancer because, as you can see from the statistics, lung cancer mortality is a significant problem in the state of Mississippi. Overall, Mississippi has the 4th highest lung cancer mortality rate in the nation. And when we look at this by gender and by race, we see that both Black males and white males have the 2nd highest lung cancer mortality rate in the nation. And with our program, we didn't want to really focus on preventing lung cancer through screening or smoking cessation. We wanted to focus on enhancing survivorship and therefore reducing mortality among individuals who are already diagnosed with lung cancer. So the goals of our program were to develop a cost-effective and sustainable ECHO program. So we used the Project ECHO model. We also aim to increase the capacity of community health workers across the state of Mississippi to deliver survivorship information to lung cancer survivors. And you can see from this map, we were able to reach 98 community health workers across the entire state of Mississippi. And I'm really quite proud about this because our program reached into areas that have some of the highest mortality rates in the nation. Our program was divided into 3 60-minute sessions, and that was followed by the delivery of a printed resource toolkit that we call the Lung Cancer Resource Toolkit. Our first session focused on information about diagnosis, treatment, challenges, and new technologies was led by Jimmy Wells, who is an oncology nurse navigator in Mississippi. Our second session was focused on resources for survivors and was led by Nancy Smith, who is a 10-year lung cancer survivor and a lung cancer advocate. She discussed local resources for patients in treatment as well as survivor organizations. And this was extremely important because we wanted to make sure that our community health workers were able to provide information for local resources. Then we also had our third session that was focused on expected follow-up and lifestyle for those who were diagnosed with lung cancer. And that was led by Dr. Jonathan Hansens, who's at the University of Mississippi Medical Center, Center for Tobacco Treatment, Education, and Research. And he focused on the importance of smoking cessation among lung cancer survivors. And believe it or not, about 50% of people who are diagnosed with lung cancer and smoke at the time of diagnosis continue to smoke. So that's why he focused on smoking cessation, as well as continued lung cancer screening after diagnosis and treatment, and other types of lifestyle behaviors that can enhance survivorship. And following the third session, all of our participants received in the mail a printed notebook that we call our Lung Cancer Resource Toolkit that was full of information that they could share with the community members that they worked with. By conducting this program, we were able to train 98 community health workers. Our evaluation results showed that there was a significant increase in perceived knowledge about the topics of the sessions, as well as positive intentions to use the information in the work that they do in their communities. We also saw significant increases in lung cancer knowledge before and after the program, and we saw significant increases in self-efficacy for delivering lung cancer education information to survivors before and after our program. This quote from a participant represents some of the positive quotes that we received during our evaluation process. This participant said, "Every bit of information was very valuable. The presenters were very knowledgeable about the subject of lung cancer awareness and prevention. Additionally, information was provided in ways that it could easily be understood." Some of the key takeaways that I would like to share today in working with community health workers is, number one, be aware of technology limitations. Some community health workers, especially those who work in low resource settings such as Mississippi, may not be able to access stable networks. And because we use the ECHO model, all of our training programs were done via Zoom. And sometimes I did get emails after the program saying that people were not able to connect because of connectivity issues. So you have to be aware of those technology limitations. In addition, about 9% of our participants were Hispanic, and therefore there was a need to make sure that we had multilingual materials available. So understanding the makeup of the community health workers that you're working with is important so that you're giving them culturally appropriate training materials. In addition, we allowed for makeup sessions because of how we structured our program. Our program was structured in 4 cohorts. And therefore, if someone missed a section in one cohort, they were able to make it up in a subsequent cohort. And by looking at the data and looking at how many people actually attended makeup sessions, I was able to see that that helped to make sure that we achieved our target enrollment. In addition, over-enrolling is very important because we know that sometimes people have very good intentions to attend a training program when they enroll, but life happens, people get busy, and they don't actually attend. So we were able to reach our target by over-enrolling for each cohort. And for example, our ultimate target initially was 100 people. And so we said, okay, well, let's enroll 25 people per session. Well, I quickly realized that that was not going to actually help us to achieve our goal of 100. So we over-enrolled for each session because we knew that some people were not going to attend after they enrolled. Another key takeaway is that there's a very high demand for training among our community health workers for cancer education topics, not just lung cancer, but a wide range of cancer education topics. As you can see from this quote from a participant, they said, "While this might not go for everyone, I would like to have little lengthier sessions or a few more of them. There are so many topics that not all of them could get explored in depth." And she's right. We had to concentrate a lot of information into 3 60-minute sessions. But we did that because we wanted to make sure that we were able to reach our audience and share those key things. However, had we had more sessions or more time, we definitely could have gone more in depth on each of the topics that we focused on. But it's great to know that this type of information is in demand. So we need to make sure that we're continuing to develop projects and programs that are aimed at training our community health workers and community health navigators to deliver cancer education information on a variety of different topics. I hope that these takeaways will be helpful for the work that you're doing in your communities. Thanks.
Hello, everyone. I'm Courtney. I'm from the Virginia Harm Reduction Coalition. The Virginia Harm Reduction Comprehensive Harm Reduction Agency that prioritizes working and advocating for people who use drugs. As a peer-run organization, we coordinate patient navigation services for testing, vaccinations, and provide educational activities specifically for individuals at high risk for viral hepatitis in Southwest Virginia. We provide safe use supplies as well and collaborate with community partners to meet people where they're at in order to support and empower them. We help restore dignity and self-determination. We hold hope for people until they can hold it for themselves. We have 2 brick and mortar offices. We also do mobile outreach. We have the Roanoke City Service Area and the West Piedmont District, which encompasses Martinsville, Henry County, Patrick County, and Franklin County. We partner with the local health department for routine testing and vaccination events. This is a list of services that we provide. Today, we're going to mainly focus on the viral hepatitis patient navigation, but all of these services play a role in preventing hepatocellular carcinoma. Our main goal is always to mitigate harm and reduce cancer risk among people who use drugs in Appalachia and Southwest Virginia. We do this by delivering safe use supplies, harm reduction education, HIV and Hep C testing, various patient navigation, and linkage to care. These are some of the barriers and challenges we continue to have, which are pretty standard amongst any public health setting. However, I'm going to highlight 2 that impact our community significantly, and those 2 are addressing social determinants of health and limited funding for various things, but especially for viral hepatitis patient navigation. I currently have a wait list of over 300 people that have identified interest in getting their Hep C treated. And there's only me in the Roanoke area and our other patient navigator in the West Piedmont area. Here are a few numbers to show the impact that we have made. Each number represents an incidence of a person who is marginalized and criminalized doing something to reduce their risk of cancer, despite their current circumstances or substance use. This is a treatment cascade from a model of care that has been designed to remove as many barriers as possible and truly meet people where they're at. We have seen amazing results when we are not bound by bureaucratic red tape. And this is more of a visual representation of the data before. So looking forward, we know this model is successful and we need to scale it up. But first, we have to identify funding sources for additional treatment navigators. Like I said, I'm only one person. Our patient navigator just got trained in phlebotomy and is in the process of starting to do lab draws in the office. So we have standing orders from our infectious disease doctor that provides a treatment. So the goal is to go from rapid testing and immediately get the labs. Therefore, we will remove another step and won't lose somebody to follow up. We're also advocating for approval of a rapid hepatitis antigen testing. We're involved in various coalitions and stuff. We would also like to explore the role of housing security on Hep C treatment outcomes. Addressing Hep C in people who use drugs is crucial for cancer prevention. And with the right model of care, which we believe we have, we can eliminate Hep C. Thank you.
I am muted, shocker. Thank you everyone for the wonderful presentations. We definitely have a lot of questions in the chat, but I think the one thing that I want to acknowledge before we jump to that is, one, I knew we were going to have people from all over the country. We've got 400 plus people still on here. I'm not going to name all the states, but I will name a couple of, we've got someone from Kenya and someone from Chile joining us. And then of course, across the United States. So thank you everybody for joining us. I want to compliment each one of you on the amazing work you're doing in navigation, screening, and then each one of your disease states. Just listening to the presentations, Pearson, your ending quote, people don't care how much you know until they how much you care. That was just really profounding to me. So thank you for including that in your presentation. Dung, maybe this will be a question, but just getting past the stigma and educating patients, regardless, I think if you're Vietnamese, whether you're a CEO of a company, going in for a cancer screening is scary. So thank you. And your impact is incredible.
And then Dr. Williams, regarding echo, I want to dive into this a little bit because we know typically CHW work has started on the early part of the continuum, but the fact that you've engaged that in survivorship, I applaud you. And then Courtney, the work that you're doing is profound. So I just want to acknowledge each one of you that we're here. And then especially looking at the locations that each one of you are sitting in between West Virginia, California, Mississippi, and Chicago. Each one of you have very distinct, I feel like, communities. So I don't know if that's maybe the kickoff. If, one, either A, that's why you dove into this work, or how you really engage your communities, because each one of them is so unique between rural and urban. So I see Dr. Williams shaking her head if somebody wants to jump in first.
Sure. So yes, for people who haven't actually lived in Mississippi, you might not understand how unique it really is. It's a great place, but unfortunately there are a lot of limitations that we have to deal with in terms of being a state that has a large percentage of it being medically underserved. And so we've been able to really adapt a lot of things to make it work for us with the limitations that we have and the populations that we have. But I've been doing work in Mississippi since I was doing my pre-doctoral training. That was like some of the first research I did. We would go down to Mississippi from Alabama on the weekends in the Delta. And so just experiencing that over almost 10 years now, you just see all of the need that is there. And of course, I've lived in different places. And like I said, Mississippi is quite a unique place in terms of the limitations and the challenges that are present.
Wonderful. Wonderful. And then Courtney, I know you discussed this, but I just want to hear about some of your passion behind the work that you're doing.
A lot of my passion is based on lived experience. So I was unhoused and on drugs for many years. I used to be a nurse, and typical Appalachian, story. If you've seen the show Dope Sick, had a back injury and ended up unhoused in Roanoke. So because of that, I'm very committed. I know firsthand the trauma that one can get dealing with the healthcare system. And so I just really am dedicated to trying to make things as easy as possible for people that are constantly in survival mode. It's hard to ask someone to prioritize, their care when they're just trying to figure out where they're going to sleep and eat. So,
wow, trying to keep some emotions back. That's a very powerful story. And thank you. Thank you. Thank you. And then I kind of want to ask the same thing to both Dr. Pierce and Dung, saying, we all come into this space. I lost both my parents to cancer. We all have our stories, but Dung, do you want to speak to kind of what draw you into this? And I do have a very specific question in a second for Dr. Pierce, but I want to hear
yes,
your
for
stories.
sure. It's also come from my own personal experience doing this work, because as immigrant coming over, I myself this experience the challenges of accessing to care, considering that I am at the younger age, could speak English. It's still very hard to get what you need. And to see that other people who come over at their older age, they have to worry a lot about how to make their life here and make the living, don't have the chance for education, don't have the chance to go study in English, and overlook the healthcare and don't have access to the care they need. Sometimes I see them and I see them as they just like my parents, they just like my grandparents. So that's why we're seeing how important is the work of navigation to give them that hand-holding chance, just to get them to the care that they need. Because even with I myself, I used to have an incident that I have, constant seeing blood in my stool, and just tried to get checked and tried to seek for a colonoscopy. And I was told even with insurance and things stuff, because it's not at the screening aid, they want to charge me 10,000 or even more than that. Seeing all that, we want to do this work and want to make it accessible for who's out there that need that screening. And as we're hearing more and more cases of people, younger people dying because of cancer, because they cannot get into the screening and the diagnostic as early as possible. So that is just heartbreaking. And I believe that all of us here doing this work because of that passion, and we want to make a change, you know, in the community. And even with me coming here to trying to work in the community, provide that education, for your question about the specific community, like the Vietnamese community in Orange County is very unique. It stems from the refugee population, and there's like political sensitivity around that. As you know, in the education, language choice, wording, even for myself, I have to learn a lesson that, okay, for, you know, to say that in the Vietnamese language. There's two different ways. It's like before 75 Vietnamese and after 75 Vietnamese, and you have to like find the balance between that to try to reach the community and deliver the messages in a very politically correct way and community-friendly way, just to get them in.
That's an amazing voice. Thank you. And then Dr. Pierce, I'm going to ask you a question, but I also want to hear again, I know we've talked about this, but just kind of your voice and story, and then I'll ask you the question that did come through the chat.
Absolutely. So what got me into this work is that my mother is a two-time breast cancer survivor. I've had two aunts die from breast cancer, and my grandfather actually died from colon cancer. So cancer has impacted me profoundly. And what's geographically different here about Chicago is we aren't a normal urban city, I think, compared to a lot of urban cities. We've done comparison studies. We are a segregated city, and where you live here in the city of Chicago matters. And specifically, if you happen to be Black or Latina, you happen to fall within the geographic map of where disparities will lie, not just for cancer, for anything. We like to say that the map looks the same, regardless if it's diabetes, hypertension, cancer. It is always the same communities dying at earlier rates. And that is why I'm doing this, because I do come from the west side of Chicago and I plan to save my community. So we are doing that work.
That's amazing. And so I'm going to piggyback on the question that did come through. So much great work is being done. Please allow Equal Hope Dr. Thomas to speak to how CHWs educate patients' children about cancer. What type of programming for children? And is it generic, non-age specific?
Yeah, so EcoHope specifically does not always target our education model to children, but to families. And so what's really important here, and this is really where our nurse navigation model comes in, our nurses do an amazing job to basically keep the family updated, to help them become advocates on behalf of the patient, but then also have those tough conversations. A lot of our patients have kids or their grandmothers who are taking care of kids, some of that third generation movement. And so a lot of times to help them understand what the patient will need as they go through this is really important, but then to also be understanding like there's going to be good and bad days. And our nurses do an amazing job of breaking that down and creating a family approach education way of doing this. So not that we have a specific curriculum for children, just our nurses are amazing. They've done it. We have one nurse who has done this for over 40 years. They really are experts in everything that they do. So they show up and they show out, and our community loves them.
That's amazing. That's amazing. And then let me go through the questions. So, and this may be actually for everybody is, and it wasn't directed to one individual panelist, but what is your experience of navigation and mental health? I think it all ties together. So I'm going to throw it out to the group.
The navigator's mental health, or
well, you can probably honestly answer it twofold. You could probably say the navigator addressing mental health, and then the navigator making sure that they're maintaining their own mental health. So maybe that's a twofold question that they did not realize we were about to pose.
Yeah, I can speak to that. A lot of people that I work with have a lot of untreated mental health, diagnoses. And so we just really try to approach them in a very trauma-informed manner. It's not always easy. I have my own mental health issues, so for me, as far as like the twofold part, like I have to do self-care and also teach, my participants about self-care. That self-care isn't always, it's almost never a mani-pedi, it's trying to eat as healthy as possible, hydrating, getting enough rest, and helping, my participants think out of the box, because when you don't have somewhere to sleep, how do you get enough rest? I use dim lighting in my office. I have a couch in case they want to kick back and, I'll catch up on notes, but, just meeting people where they're at. And I think just giving people that dignity sometimes helps them overall with their mental health. But what I find is that a lot of people then want to address, their mental health in a more clinical fashion after they see, that they got someone to go to bat for them. I don't know if that makes sense, but
Yeah, no, I think it does. I think it does. What about
Yeah,
from
so
the
that's
rest of our panelists?
Yeah, I was going to say, to that point, it is really important to take care of the mental health of not just the navigator, community health worker, but the community. In our work, we're going into some of Chicago's most underserved communities, meaning there may be higher gun violence. Usually people stay away from those communities. It's not really where outreach. And so our team is actually doing boots on the ground work, where they're walking around communities and just meeting people in their everyday life. That comes with certain challenges, because you may have people who lean on you or want to tell you their story. And sometimes that can evoke a certain trauma out of the staff themselves. So we do prioritize that. We've implemented mental health days. They get an additional mental health on top of the other days that they have to take to themselves to just reset. We also have those really transparent conversations with the community, whether it's around our physical health or our mental health. We found that just having someone you can relate to who's been through a similar situation is really how the community opens up to us, and we encourage and then provide those resources for them.
Amazing. We did have another question come through. Again, a lot of thanks and praise and, hand claps and hearts and everything. I think just telling your stories from, what you do and then your personal experiences. It says, thank you to the speakers for taking time to share your work and experiences. How have you all managed keeping the balance between helping individuals, recognizing they need preventive care, which is the point of today and what everything that Prevent Cancer Foundation is doing, and overstepping when they may not be yet prepared to accept taking more control over their health? Like, how do you have those tough conversations, or raw conversations? I'll say, maybe not tough, but raw.
So I think it kind of comes down to like the science of motivation and understanding what would motivate an individual to engage in preventative care. And then also understanding that sometimes no matter what you do, they're not going to do it until they get ready. So making sure that they have the access that they need to have when they're ready to go and do that. But providing education is important. But like I said, not trying to force it down anyone's throat, because that could further traumatize someone, especially if someone is avoiding care because of a traumatic experience or a discriminating experience. Trying to force them to engage in it is not going to be effective, but just empowering them, making sure that they have the skills and abilities and the ability to access care when they're ready.
I think also, like, we have a hard time accepting that people have the right to self-determination in their own agency, because we think we know better what they should do, and that's a hard line to walk. Like, and what I was thinking about is I had this one participant who I was helping through the Hep C stuff, and he had like stage 4 lung cancer and knew it, and he had no desire for any kind of treatment. He wanted to do the other stuff, and every doctor that I brought him to for anything else would start to try to get him to do some kind of treatment. And, he avoided taking care of other things about his health because he did not want the treatment. Like, he did not want to do any kind of anything. And that was mainly after I got built rapport with him, got talking with him, is he took care of his mother in a similar situation, and, was very traumatized by that and did not want to experience that. And, you got to respect where a person's at sometimes. I think that's important. And sometimes having those hard conversations is just having the hard conversation, asking those questions. You know, most people are willing to tell you where they are and who they're about, you know what I'm saying? But if you're just like straightforward and authentic with them, so.
Exactly. And even thinking back to the beginning when we kicked everything off, it's those, you know, experiences with the healthcare system. You know, if you have a bad experience, whether it's yourself, to your point, Courtney, you know, watching somebody else go through something, you know, they're gonna keep hold of that. So that's a great statement. So I have two questions, and it's related to colorectal cancer screening in two different places. And it's going to be a twofold question. How do you address the issue of patients not having an escort or someone to pick them up after a colonoscopy? Because I think about that. I've got to get mine, and gracious. I'm lucky to have, I don't have young drivers yet, or another procedure. Do you have ideas on how to remove this barrier? And then I'll ask the second question. Somebody said something about ride share. So I don't know if this is something that y'all have experienced in your practices.
So for us here, we do have a program on colorectal cancer screening, and the part that connect them to the colonoscopy procedure, and the compliance is a very tricky part, because there's also misunderstanding in the community about it is a very invasive and painful procedure, which is not really true. And so one of the things that we do is that we try to have more people sharing their own experience with the colonoscopy procedure. That's very helpful to get people in. And for the ride share right now, for us, VACF currently don't have like any specific program to offer that help to them, but we do have some of the volunteer that they would be willing to support the patient for that screening portion. And in California, if they have the Medi-Cal insurance, which is the low-income population, Medicaid in California called Medi-Cal. If you are in Winton, Orange County, it does pay for the ride share for them to go to the procedure and then go back to their home. But we face the challenge of the ride share is right now, you know, it's hard in a way, is that the managed care plan work with a third party, and the patient having a hard time to schedule the ride by themselves. So our navigator act as that facilitator, help them schedule the ride and inform them about the ride that come, and connect them like at point like that. Basically, on the day that they have an appointment, we kind of being like virtually remotely from our office, help to facilitate that sort of conversation between driver and then the patients. That's what we do here.
Wonderful, thank you. And then I know we're gonna start, I've got about 3 minutes left, but I do want to share some comments that we are getting through here. Especially around listening from the 2 questions ago, just how do you get people, like meet them where they're at? So one comment, meeting people where they are speaks volumes in our work as navigators. Lead by example is also important, that we relate to real life issues and barriers while addressing the navigation process and delivery of resources and care and patient navigation roles. So I think that's a great takeaway, one, for these amazing panelists, and then everyone listening. And then just reiterating, you need to listen to the person and what they're telling you, rather than trying to get them to do your testing, etc. So, I mean, these are very passionate voices that I'm listening to. So thank you, everyone that's chiming in. And then let me scroll through before they give me the red flag of you got to stop. Talking about and then one thing we did get, and I don't know if our panelists saw this, if you're willing to, and I can talk to obviously our leaders at Prevent Cancer Foundation around sharing your contact information, because I think everybody got a lot from you. I know Courtney, you've shared yours, and I think one or two of you others have shared. But if you're willing to, you may get an influx of inquiries very, very soon, just from the amazing work you're doing. So, and then anything we have not answered, I know that Heather and Adrian said that we will put something together and answer those questions. So we may be reaching out to each one of you to put that together. So any parting words in the last maybe 90 seconds we have?
I'll just say thank you to everyone that attended. We have a lot of people, so thank you all so much, and for the work that you are doing and that you will be doing.
Dr. Thomas, anything you want to jump into? I'm going to call you out. I'm not afraid.
No, I echo the same things as Dr. Williams, but also thank you, Prevent Cancer, for this platform to be able to share our models and the work that we're doing.
Courtney?
Yeah, I'm gonna echo what everyone else said. Thank you. You know, it's not there's not too many spaces that I have been in that aren't, you know, harm reduction or substance use specific. So it's nice to see how it all kind of comes together. Thank you.
And last but not least, Dung, how about you?
Thank you, everyone. Just want to echo everyone and very appreciate to have the opportunity to see folks on the ground that's doing, the same work, trying to address the same issue in addressing cancer.
Absolutely. So I am going to, I think, turn it over to Heather. Are you wrapping us up?
Yes, ma'am. Not sure how I can wrap us up after that wonderful discussion, but thank you all. To echo Monica and each person, apparently didn't start my video, to echo everything that was said. It is our deepest appreciation to have each of you here and to be able to share your stories. Thank you to each of you that participated in the chat, sharing your experiences. I think one of the toughest things about being virtual is really that opportunity to connect and network and really, so it's one of the things we miss about being together, but I think you guys have done a tremendous job with being able to get that information out, to make available, to share with one another. As Monica mentioned, we will be putting together a document that will put things into any of the questions that we didn't get to. We want to make sure to have those available, and we will be following up with each of our speakers to get that information, and we'll upload a document to the e-learning website about a week following today's presentation, which is where you'll also be able to get copies of your slides and all the recordings from today's events. So thank you to all of our speakers. We want to make sure we hear from you about what you found valuable about today's presentations and opportunities that we have to improve for future presentations. So be sure to complete your evaluation. If possible, we'd love to have you drop a chat or drop a highlight in the chat of what you've learned, what you're going to take back and implement into your practice based on your learnings today, and be able to share that information with one another. When you're looking for information about any questions that you may have that you can't find on the e-learning site, please feel free. On the FAQ, you'll see a way to reach out to us to get more information so that we can be able to provide that CE information in terms of the steps you need to complete. Very important. And I'm kind of speeding through this because I know we're close to time. And I know that as many of you have seen in our promotional materials, now is the fun part leading up to today's event. The Prevent Cancer Foundation, and as you see on the slide there, that we do have the program evaluation that we'll make sure to fill out so that you've got your CE information for those of you that are obtaining CHESS credits or CE credits. So make sure and look for that portion of the program evaluation in the e-learning system so you can find that information. For those of you, and I keep losing if you wonder why I'm looking around madly, it's because I keep losing my document. I want to make sure I get all these details straight or else I'm going to bankrupt our foundation. The Prevent Cancer Foundation is very excited to announce that we will be awarding up to 30 stipends of $2,500 each to our community organizations that are working to address an unmet need by bolstering patient navigation and cancer screening and early detection efforts. Only those who attended today's live event will be eligible for the stipend. You can find more details, including a link to the application, in the stipend tab on the program page of the e-learning site or in an email that you're going to receive following today's event. Be sure to review this information carefully before completing your evaluation. All applications must be submitted by Friday, July the 5th. We can't wait to see how you're going to put these learnings into action. Separate from the dialogue stipend, we're also going to be launching our 2024 community grant application very soon. This is the same program that several members on our best practices panel received funding from for their work. Be on the lookout for information about the community grant application, which will be opening this summer for US-based nonprofits. This year's grants will be in the amount of $100,000 over a 2-year period and will also focus on patient navigation efforts for cancer screening and early detection. More details will be available on our website soon at preventcancer.org/community. While there, be sure to add your email address to the online form to be notified when applications open. Be sure to join us for our next and final Prevent Cancer Dialogue webinar of 2024, an update in prostate cancer screening, which will be held on September 11th, 2024. More details will be added soon as speakers are finalized, and you can register for that session on the e-learning platform. We'll hope you'll be able to join us then, and thank you for being part of Dialogue.